Okay, so welcome everybody, and sorry for starting a little bit late, but I was caught in a traffic jam on the way home, and there was a big car crash. I don't think anybody got hurt, but unfortunately, it caused a bit of a delay. So sorry about that, but don't worry because we'll be able to finish on time. So we are today having our second session. And according to the timetable, we're going to be talking about infertility, recurrent miscarriages, and maternal-fetal immunology. So please feel free to interrupt. I mean, if you need to ask questions or write in the chat. If you write in the chat, probably what we'll do like last time, that I'll go through the questions in the chat and then answer at the end. But please, if at any point you don't hear me well, or the connection gets lost, or the sound goes low, please just unmute and let me know. Thank you. So let's start off. Just waiting for the slide to move. Okay, so today we're building on what we covered in session 1, where we went into quite a lot of detail on the basics of reproductive physiology. And I think, one of the human rights must be that every individual must be aware of at least the very basics of human reproductive physiology in order to be able to live a healthy life. Okay? And by leading a healthy life, of course, that is important not only for themselves, but even for starting off and keeping a healthy family. Or shall I say, in order to be able to conceive without any problems. So this is a slide taken from the first session presentation, but just to remind you that when we talk of the female reproductive physiology, we are really and truly, if we narrow it down, it is based on a number of hormones which start off in the brain, and specifically in the pituitary, where we've got the follicle stimulating hormone, which in a girl or a woman, after puberty, it starts triggering the formation, of follicles. That's why it's called follicle stimulating hormone. And then, as we start approaching the mid part of the cycle, the LH causes a trigger that is causes ovulation to happen. And in the meantime, under the effect of FSH and the follicles which are forming, the lining, which would have just been shed with the previous period, would be proliferating. And by the time that the ovulation would have happened, by then the lining is thick enough in order to be ready to go on to the next phase, the secretory phase, which starts off upon the secretion of progesterone. And progesterone, just to remind you, is secreted by what is left from the coverings of the egg. So once the egg is released, what remains of its coverings form the corpus luteum, and that produces progesterone. And should there be a pregnancy, right? So should there be a sperm which manages to meet the egg and there is conception, so fertilization has happened, that normally happens within the fallopian tube. Okay, so I'm sure you all know, of course, during intercourse, the sperm will travel up from the cervix and into the uterine cavity up to the fallopian tubes. And for example, if ovulation this month has happened from this over here, then if there is sperm present at the right time, then conception will happen in the fallopian tube. So, as you know, back from the basics of biology, normally approximately one egg is released, but of course, in a sample of sperm, there would be millions of sperm. And those sperm which actually manage to reach the fallopian tube ready and able to fertilize the egg, from those millions of sperm, you're left with approximately about 40 to 50 in the case of human sperm, and those 40 to 50, only one of them manages to fertilize the egg, and if that is successful, then you've got a new individual, the embryo, which would result as a result of that fertilization. And of course, when that happens, right, it takes about 5 days for the embryo to travel from the fallopian tube to the uterine cavity, and then implantation happens by day 5. And once that happens, the HCG, which is released by the trophoblast, right, from the developing embryo, will maintain and further enrich the uterine lining, which by then becomes called the decidua. And of course, that happens because of the release of HCG. So again, I know this is a bit of a repetition from last session, but since we're going to be talking about infertility and miscarriages, just to go back to basics and just, set the scene. Okay, so the first topic that I'm going to be covering today is infertility. It's a subject which is very close to my heart, because my PhD was actually on early pregnancy failure, that is early miscarriage, and very often that is also linked very much with infertility, because when there is early pregnancy loss, like before implantation or just around the time of implantation, patient might not even know that they were pregnant. And if they are trying to get pregnant, of course, if the embryo doesn't manage to start secreting HCG, they would never know that they're pregnant. And it is a big deal for many people, of course, and it causes a lot of emotional and psychological distress among couples and among even the extended family. So, when we talk of infertility, what are we referring to? Now, it's important to keep in mind that there is such a thing as primary infertility and secondary infertility. And the definition of primary infertility is basically the inability of a sexually active, non-contracepting, heterosexual couple who try to achieve a pregnancy, but they are unable to after a year of trying, right after a year of regular intercourse. This is the standard definition, which is assigned by the WHO and the International Confederation of Medically Assisted Reproductive Technologies. And of course, you have patients coming to see you before that, and especially, if they kind of expect that they would get pregnant with the very first time that they're intimate, and of course, as time starts passing, they might come to contact you before, or as happens in the majority of cases, they usually present after more than a year. But we use that cutoff of a year mainly because in general, as we'll see later on, most couples who are otherwise healthy, and most couples, like 84% of couples, would manage to get pregnant within the year. So within a year of trying normally, having intercourse around the time of ovulation, and maybe even more frequently, they normally manage. And then
Hello,
you're
Paul.
left with the 50. Yes?
Yeah, sorry.
Hello?
Please, are you sharing your screen?
Yes, I should be. Is it not showing?
No, please.
No? Okay, so let me stop sharing and start sharing again. Sorry about that.
Okay.
So I didn't realize. So let's share again. And okay, so was it from the big? So is this the only slide that you have seen?
Yes.
I'm
Yes.
sorry about that, and thank you for letting me know because I didn't realize. Okay, sorry about that. So let's just, okay, let me just go back. So this was the introduction, right? And this is where I've said that every individual must be aware of the basics of human reproduction, all right, in order to be able to lead a healthy life. Then I was explaining about the menstrual and ovarian cycle. This is taken from the slide of the first session, okay? And then I was saying that normally conception happens in the fallopian tube, okay? And then, I was showing this slide to show that by the time the ovulation happens, I mean, this is the egg over here, and by the time that ovulation happens, although when a couple are intimate, there would be millions of sperm, around 15 to 20 million at least sperm, which are, present. In that case, I mean, only about 40 to 50 sperm manage to reach the egg in good health. And one of these is needed for fertilization to happen. And then I was again showing a slide from the previous session where I explained that once implantation happens, then the HCG is triggered by the syncytiotrophoblast from the implanted embryo, and that HCG will maintain the uterine lining and maintain the pregnancy for the 9 months. And then, I mean, this is where I was saying about the problem of infertility. And when it comes to the definition of infertility, so the WHO definition, I repeat because this is very important, is the inability of a sexually active, non-contracepting, heterosexual couple who are unable to achieve a pregnancy within 1 year. Okay? And the definition of 1 year lies because you have, on average, in a healthy couple of normal reproductive age, 84% of couples manage to achieve a pregnancy. So then that leaves you with about 15 to 16% who haven't managed to get pregnant after 1 year of trying. That approximately boils down to 1 in 7 couples. Okay, again, I'm talking of normal reproductive age. And there is where investigation needs to start. Now, of course, you need to use your clinical judgment. What do I mean? So if you are, if you have a couple where, for example, let's say the lady has undergone chemotherapy, all right, or has undergone pelvic surgery, which might have compromised her fertility. I mean, in that case, you are not really going to apply the 1 year 1 year mark. I mean, you're going to start at least investigating before to check her ovarian reserve. Same in the case of the male. I mean, if the male has undergone treatment which might have compromised his fertility, right? Or, of course, the age of the couple, particularly the age of the female, is such that her fertility might be compromised, and by waiting another year, it might make the situation worse. Of course, you use your clinical judgment to start before. But this definition is still important, especially when you're dealing like with the general public. And as I said, you get couples who, let's say, recently got married, and within 3 months, like they come panicked because they haven't got pregnant yet. And in that case, you reassure and you take a medical history. And if there is nothing suspicious in medical history, you let them be and tell them to return, within a year. And the idea is, in order to avoid over-investigation or avoid starting infertility treatment, particularly IVF, too early. And unfortunately, we are very much aware, as I'm sure you are, of situations where couples might be going privately and they are quickly rushed, I would say, use the term rushed, to go through expensive IVF treatment, which might be unnecessary. And I'm sure you've met couples like I have who have been going through, 2 or 3 or even more IVF cycles, unsuccessful, and then, they kind of give up. They stop trying to have IVF, and then they fall pregnant, without any medical intervention. So that's why we use this definition. As I said, use your clinical judgment, and it's important to take a clinical history because there might be a number of exceptions where you don't stick to the 1 year. As I said, I mean, the most common being if either of the partners has undergone some type of treatment which might have compromised their fertility, for example, chemotherapy or radiotherapy or surgery, etc. And I'd also like to point out that this is the definition of primary infertility, meaning that none of the partners have ever been pregnant, right, within that relationship. So not even any miscarriage, for example, or any stillbirth. And that is to make it a bit distinct from secondary infertility. So secondary infertility is when a couple, between them, they've already been pregnant. Now, it might be that that pregnancy led to a live birth, and now they're trying for baby number two, but this baby number two is not coming yet. Or it might be that, unfortunately, the first pregnancy ended up in a miscarriage or a stillbirth. But it's important to make a distinction between primary and secondary because, of course, in secondary infertility, of course, while still very distressing for patients, but especially if there has been a previous normal healthy live birth, I mean, you tend to be a bit more, let's say, relaxed in terms of when to start treatment. Of course, I mean, you might still have to start treatment for a couple who already had a previous normal health live birth, especially if there are issues with having a second baby. But let's say, the underlying causes tend to be, unless of course something happened between the first and second pregnancy. So let's say one of the partners, unfortunately, between the first and second pregnancy, had to undergo fertility compromising surgery or fertility compromising treatment. Of course, then in that situation, it's understandable why you'd need to intervene. Primary fertility, as I said, is when there has been no previous pregnancy at all. Just to make sure that you're seeing this new slide now, which is called "What are the main causes of primary infertility?" Just to make sure that the slides are moving. Can I just confirm that you can see the new slide, please? Which reads, "What are the main causes of primary infertility?" So, Abigail, can I just confirm, please? Yes, okay, thank you. Just to make sure that no, there are no technical issues. Okay, so what are the main causes of primary infertility? So for a very long time, we used to think that, of course, if there's infertility, it's a female problem. But now we know, I think the past few years, it has definitely, becoming more obvious that there are a number of factors. I mean, you've got around 40% of causes of infertility, which we label as female factor, meaning that it's a problem with the female partner. And it could be hormonal or it might be non-hormonal. Another 40%, so same as the female, another 40% are due to male factor causes. And again, they might be hormonal and they might be non-hormonal. And I'm not sure what the statistics for Ghana are, but what I can tell you that here in Europe, we are seeing more and more male factor infertility. So probably, when this concept of infertility and infertility treatment started off, as I said, I mean, the blame was most of the time put on the female. And then we started saying, yes, it's because females are taking longer before they get pregnant because of career and studying, etc. But what we're seeing, I mean, it's a phenomenon that we're definitely seeing here in Europe, that there is a rise in the male factor infertility. I mean, we're not sure exactly if there is a rise or it's always been there, but we never investigated. But certainly 40% of cases of primary infertility are due to problems with the male, be it hormonal or non-hormonal. And then on average, you've got about 20% where we label them as unexplained causes of infertility. It doesn't mean that necessarily there isn't a problem, but with the current means, with the current investigations that we have, you don't find a cause. Those, the unexplained infertility, are probably the most difficult to treat because you kind of feel split whether to start any medical intervention or not, because you can't find anything like to treat. And it's true, yes, it's usually a question of waiting and then it happens. But I mean, they are probably the couples who, let's say, pain me the most when it comes to managing. Okay. Believe it or not, when you find a problem, then you kind of know what the situation is, and even the patients, they tend to accept it more. When it's unexplained infertility, it's even emotionally and psychologically, it's even more distressing for the couple. Okay, so let's start a little bit with male factor infertility. And here I put, probably I try to list most of the commonest causes of male factor infertility. So when it comes to non-hormonal, right, usually that involves blockage of sperm transport, and tends to be a physical blockage or a neurological blockage. And probably the most common cause being infections or prostate-related problems. There might be developmental problems like an absence of vas deferens, for example, and might be antibodies, might be injury, and of course, if there has been previous surgery, including a previous vasectomy, which can be reversed. There are, of course, also lifestyle factors, and we do believe that probably it's one of the main causes of male factor infertility. And again, certainly in Europe, I mean, poor diet, unhealthy lifestyle, mostly because of stress or unhealthy sleeping patterns, and smoking, of course, use of illicit drugs, and those have an impact on the fertility in males. Then, of course, there might also be problems of sperm production, and these problems of sperm production could be physical causes, could be hormonal issues, right? So, of course, in the same way that you had the LH and FSH in the case of the female to produce ovulation, you have LH and FSH, which are responsible for the gametogenesis, for spermatogenesis. So if there are problems with hormones, of course, there will be problems with production of sperm, and even things like, for example, pituitary tumors like prolactinoma. And then there could also be physical problems, like, for example, undescended testes, previous injury, varicocele, previous treatment like drugs or radiation damage, or actually mechanical problems like retrograde or premature ejaculation, failure of ejaculation, and previous surgery. These, of course, all contribute to male factor infertility. And so, yes, that is trying to put all those causes in one. I mean, the list is not exhaustive, but I think I put the most common ones. When it comes to female factor infertility, probably we do know a bit more about female factor infertility, probably because we do know a little bit more about the female reproductive physiology. And as I said, there could be hormonal versus non-hormonal factors. The hormonal factors normally they are focused on ovarian factor, meaning the production of ovulation, and the problem could come up from the either from the pituitary or the hypothalamus or the ovary itself. And then you've got the non-hormonal factors, for example, the tubal factors because of the result of pelvic adhesions, for example, from endometriosis or previous chlamydia, uterine factors, for example, multiple fibroids, which distort the uterine cavity, cervical factors like previous cervical stenosis because of previous surgery, for example. Okay. And if we focus a little bit on ovulation, which I would say probably 50% of women with infertility and because of female factor infertility, probably this does feature most on ovulation. You get two main causes. They are not the only causes, but the two commonest causes. And these would be premature menopause, low ovarian reserve. So you might have a 40-year-old or a 35-year-old who already, even though she's still within reproductive age, already she's showing high FSH, meaning that her ovarian reserve is low. It could actually also be menopause, because as we said, I mean, for a number of factors, there might be someone who has delayed at the start of the reproductive life. But then another common cause, which we do have very commonly in Europe and I would say in the Western world, and I'm sure, I mean, even in Ghana, is polycystic ovarian syndrome, which, as you probably know, has recently changed the name now to polyendocrine metabolic ovarian syndrome. Right, so I think it was just the last couple of weeks that there has been the official change to the name of polycystic ovarian syndrome. Okay, so what is it? What is PCOS, or as we said, the polyendocrine metabolic ovarian syndrome? So the crux of it really is inability for ovulation to happen on a regular basis. And what happens is, therefore, that since the eggs, the follicles which have been recruited, are unable to ovulate, you end up with a number of microcysts lining the cortex of the ovary, what we call the necklace appearance, right, on ultrasound. And all these microcysts would be containing follicles which would have been unable to ovulate. And hence the patient, if she's not ovulating or she's ovulating on an irregular basis, she would get irregular periods, typically with long periods of secondary amenorrhea, and therefore there is an ability for an egg to be formed, therefore for fertilization to happen. These signs and symptoms, the most obvious is typically the irregular menstruation, even though you can have people with polyendocrine and metabolic ovarian syndrome who have still regular periods, but they're still having anovulatory cycles. Another typical feature is the hirsutism, the excessive body hair growth in abnormal places. Of course, the ovarian cysts, and up to now, the criteria are saying that you need to have at least 2 out of these 3. It's typically accompanied by obesity and also acne, and this is because of the oily skin and with thinning of the hair, and of course, even trouble conceiving. As we were saying, the hypothalamic pituitary axis plays an important role in the control of ovulation, and this we went through it in quite a lot of detail in the previous session. And therefore, if we have someone with an ovulation, what test would you do? And in that case, if there is an ovulation, and of course, how do you realize that there is an ovulation? It's by doing hormone tests, and you can also do home ovulation kits, and they confirm that the progesterone is not rising, meaning that the ovulation is not happening. So in that case, to confirm, you run your hormone tests, which would include the FSH, the LH, the estrogen, and progesterone. particularly day 21 progesterone, or at least you aim to take a progesterone in the secretory phase, and if it doesn't rise, basically it shows that ovulation is not happening. And it's also important to think of other hormones which might affect the hypothalamic pituitary ovarian axis, and these include the thyroid itself, so doing the thyroid function test, and the prolactin, like high prolactin, which could result because of a prolactinoma or because of certain medications that the patient is taking. High prolactin will also inhibit the HPO axis, the hypothalamic pituitary ovarian axis. If she is ovulating, so you do your hormone tests and you do your day 21 progesterone and you confirm that she's ovulating, and you're looking now to confirm whether there are any non-hormonal causes of infertility, in that case, it's important to go for ultrasound, pelvic ultrasound. You can also, it's also advisable to check the tubes. You can either do that by hysterosalpingography or hysterosalpingocontrast sonography, the HICOSY. To be honest, what we routinely use over here is the pelvic ultrasound and hysterosalpingogram. At hospital, we do offer the HICOSY, but because you need dedicated, trained staff in order to be able to do that, it's not usually the first line, right? So pelvic ultrasound, so the pelvic ultrasound could be done transabdominally or even better transvaginally. If you want to look for cysts and you want to look for, endometriomas, you want to look for fibroids. And hysterosalpingogram, just to remind you what a hysterosalpingogram is, it's an X-ray. So of course the patient must not be pregnant, and it's usually done at the soon after the end of a menstrual cycle, where the patient is advised not to have any intercourse during that particular cycle. And basically under X-ray guidance, you inject a radio-opaque dye. So you use a speculum, you inject a radio-opaque dye, and this radio-opaque dye, you take films to see that the radio-opaque dye has passed through the tubes and has spilled in the pelvic cavity. And that means that the tubes, the fallopian tubes, are patent. Okay, so this is like a cartoon of what you would be seeing. So that would be the uterine cavity, and if the fallopian tubes are patent, there will be the spill happening, and like that, you know that the tubes are patent. Of course, if there is, let's say, a lesion like a myoma, like a fibroid, which is pressing over the cavity and distorting also the connection between the uterine cavity and the tubes. For example, in this case, no dye was passing on this side, meaning that the tube on that side is not patent. And in this case, there is some spill, right? There is some spill in the tube, but of course, also the tube, although it's patent, it's also not exactly in a good shape. The HICOSY, or the hysterosalpingocontrast sonography, uses the same principle of the hysterosalpingogram without exposing the patient to radiation. You still perform it at the end of a cycle, and you also advise the patient that she must not have intercourse and must not try to get pregnant in that particular month. And what happens is that the patient, in the clinic, so no need of any anesthetic or sedation, same for hysterosalpingogram. You put in a catheter, and then you inject saline, and then under ultrasound guidance, you check whether there is any spill happening through the tubes. It is very operator dependent. So that's why you need trained operators in order to be able to confirm whether the tubes are patent or not. So that's why, let's say, it's true that she's not being exposed to any radiation, but it's very operator dependent. Okay, so of course, I can't do an lecture on infertility without mentioning IVF. Just to tell you about our local situation in Malta, up till 2013, so up till 13 years ago, effectively, IVF was performed, had been performed only in the private sector. And the patients had to pay, and it was, let's say, at the mercy of the private enterprise. Then, in 2013, a law was passed which legalized IVF, right? And before there was no law, so technically it wasn't illegal, but it was not being monitored. Then in 2013, a law was passed, an embryo protection authority was set up, and IVF started being offered also in the public hospital. And over the years, it became also free for patients and doing it in the public sector, even the medications were free. So, and now I would say, from not having any IVF available in hospital over 13 years, I would say that most of the technologies are available in hospital, and up to 3 cycles, the patient don't pay. And the only thing which is thankfully not available till now is surrogacy. Even though there have been groups who have been pushing towards it, but so far we don't have surrogacy. But it is possible to do all the other techniques. So again, I mean, I will just say what IVF is about, and like just to make sure that everyone understands the terms. So way back in 1978, or was it? Yes, or 77? I think it was 1978. The first IVF baby, Louise Brown, was born in a small hospital in the United Kingdom. And yes, it is a fact that it did change the world, and it did definitely change 1978, yes, I'm right. Definitely did change also our understanding and our management of infertility. So here, so when I was doing my master's in Leeds in the UK, and my master's in clinical embryology, let's say I was lucky that I was taught by one of the doctors who was actually present. She was a junior doctor who was present when Louise Brown was born. And I'm going to show you a clip of the actual birth of Louise Brown, so the first IVF baby. And this is now also available on the internet, because you might be aware there was also a film about about this. But this is the real clip, which was filmed, look at the time, at 11:47 p.m. in July 1978. And it was a cesarean section. So Louise Brown was born by cesarean section because her mother, who had undergone IVF, she developed preeclampsia. So she had to be born by cesarean section at 38 weeks, and she was born in the middle of the night. But they filmed the birth. So I'm going to show you the video. By the way, the doctor who is operating is Dr. Patrick Steptoe. Dr. Patrick Steptoe. This is Louise Brown being born by cesarean section. And this gentleman here is Robert Edwards, who was the biologist. So he was the biologist, or who we call today an embryologist, and he was the gynecologist, Patrick Steptoe. And this was the nurse. Her name was Jean, like me, and she was the assistant basically of both of them. So she was looking after the patients as an assistant to Patrick Steptoe and also helping in the lab, well, actually also working in the lab with Bob Edwards. Okay, so I felt I had to share this with you. Sorry, let's just move now. Yeah, sorry about that. Okay, let's continue from here. Just to confirm that you're still seeing the slides. So basically what we're seeing here is a photo of
Yes,
that,
Prof, we can see it, please.
Thank you. What we're seeing is a photo of that clip that we've seen. So Patrick Steptoe, Jean, and Bob Edwards, and the first IVF baby, Louise Brown. Okay, so again, just a few, slides about the process of IVF. So what is IVF? So effectively, what it entails is, so normally, if we're to conceive spontaneously, you wait for that one ovulation to happen, and then once that ovulation happens, then and there are sperm present in the tube, the fertilization, as I said before, happens within the fallopian tube. And then the embryo moves along the fallopian tube and is implanted about 5 days later. Now, in IVF, what happens is there is hyperstimulation or overstimulation of the eggs in such a way that instead of having one ovulation happening, there are at least around 5 ovulations happening per ovary, right? So normally the treatment aims to have at least around 5 ovulations. Of course, you don't wait for those ovulations to happen spontaneously. So just before ovulation is due, an LH injection, and usually it's an ACG injection which mimics the effect of LH, is given. That's called the trigger. And rather than waiting for ovulation to happen, the eggs are retrieved by means of a small operation. So this pipette is inserted transvaginally under ultrasound guidance, and the eggs are retrieved. They are taken to the lab. Within the lab, then the eggs meet the sperm, and then you incubate between 3 to 5 days. And then once the embryo forms, that is by then an 8-cell embryo, or if you wait till day 5, it's a blastocyst. Then, depending on the protocol of the lab, the embryo is transferred under ultrasound guidance into the uterine cavity. And then you wait to see whether implantation will happen or not. And of course, to assist that, the woman is given further hormonal support, usually in the form of progesterone, in order to try to mimic what happens during normal conception. All right, so again, the steps. So you get the egg retrieval, that is also known as harvesting or the egg pickup, okay? That is done under sedation. Then this is the IVF lab in our hospital in Malta. So this is where the procedure would be happening in theater, and there's this transparent window on purpose so the people in the lab, the embryologists, can follow what's happening. Then once the eggs are retrieved, they are brought to this flow hood here, where they look under the microscope, and then they clean the eggs, and then in this area, okay, so you check that the egg is in what we call an M2, in meiosis 2, that means it's a mature egg. And then in another station within that same lab, the eggs, each egg is injected with sperm if you're going to go for something called intracytoplasmic sperm injection, or else you could also, put one egg per dish, per petri dish, and put in a dose of sperm. And that is if you're going to go for the, let's say, plain IVF. But if you were going to actually inject the sperm in the egg, you use this special microscope called the micromanipulator in order to inject one sperm in one egg, right? And then you incubate, and every day you check that the embryo is growing. And then once you reach the 8-cell stage, that's usually by day 3, you transfer, or else you wait till you've got the blastocyst, sorry, and by day 5. And the embryo is transferred, and then you wait about 2 weeks later to see whether there's a rise in HCG. Now, what I'm going to show you here, this is actually a time lapse. A time lapse means a number of labs, instead of every time taking the petri dish out from the incubator and checking under the microscope, they keep the petri dishes with the embryos inside the incubator, and there would be a video camera within the incubator itself, and you take like a video of the development of the embryo. The idea is that you don't have to keep taking out the embryo from the incubator and disturbing the environment, the oxygen levels, the temperature, and also risking contamination. So what I would like you to watch is the rapid development of the 1-cell embryo, which forms as soon as there is fertilization, to the 2-cell, 4-cell, and then 8-cell, 16-cell, and then 32. And once you arrive at 32, then you get the blastula formation. That is the separation of the inner cell mass, or the embryoblast, and the outer cell mass, or the trophoblast, which will become the placenta. And that happens, by day 5, and that is the latest that you can keep the embryo in the incubator. So let's see. So here you've got the 2 cells, right, 2 nuclei, with the first cell division. And then 4 cells. And then quickly it's going to become 8 cells. That's by their day 3. And then from 8, you've got the 16. And then the 32. And then that's the morula. And then by 32, then immediately you get blastulation. That is the separation of the inner cell mass, which will become the embryo, and the outer cell mass, which will become the trophoblast, which ultimately, upon implantation, will start secreting the HCG. And as I said, you can perform IVF by putting one egg in a petri dish and putting in a dose of sperm. But there are cases where you actually have to inject the sperm yourself, especially if there is a low sperm count, or the sperm, let's say, of poor quality, maybe they're not able to swim properly. Okay, and in that case, that is what we call intracytoplasmic sperm injection. So what you're seeing here is the egg. If you're going to perform the ICSI, the egg, you need to clean it off from the granulosa cells, or what we call the corona radiata, which are the cells accompanying it from after ovulation. You need to clean those off. So here you're left with the zona pellucida and with the egg itself. Here you see the first polar body, and you see the little sperm right within the tip of the syringe. And you're going to see how it's injected. So just watch the sperm there. Then you've got the syringe, which is going to be injected within the egg. This is done under the micromanipulator. All right, you see the sperm, and this is initially trying to escape, and then it's flushed back in. There it is, and you see it over there. Okay, then you remove the needle. Of course, you haven't injected the nucleus of the egg. You've just deposited the sperm within the egg. And then you don't have a guarantee of fertilization because you still have to wait for the nucleus of the sperm and the nucleus of the egg to fuse. And then you check after 24 hours to see if cell division has started. And then you know that fertilization has happened. Okay, so that's intracytoplasmic sperm injection. Of course, IVF has a number of ethical and moral issues with it. I mean, especially where it comes to embryo freezing, because inevitably, if you're going to collect those 10 eggs and each of them is going to be fertilized, I mean, you can't transfer 10 embryos at the same time, of course. Therefore, first, you have to deal with issues of embryo freezing. In fact, reasons why when the law in Malta was established, the initial law, I mean, it was revised over a number of years, but the initial law did not permit embryo freezing. It permitted egg freezing, so that all those eggs which were collected, you didn't have to fertilize them all, but you could only fertilize 2 or 3 at a time, and then only if patient either does not get pregnant with the first round of IVF or gets pregnant but would like to get pregnant again, every time you unfreeze, you thaw a batch of eggs so that you avoid having to have embryos which end up being frozen. The thing was that over the years, the law kept being amended, and now we are in a situation where embryo freezing is allowed and it's carried out. Of course, a number of couples are not, happy with embryo freezing, and they opt to go only for egg freezing, and they still fertilize, a small number of eggs at a time. But of course, I mean, it is also possible to have the embryo freezing. Another technique which in Malta has been introduced in 2022 is pre-implantation genetic diagnosis, which again, I mean, is also fraught, of course, with a lot of ethical and moral issues, moral dilemmas. And basically what pre-implantation genetic diagnosis entails is that if there is a couple where they know that, for example, both of them are carriers of a recessive condition, and they would like to get pregnant, but they would not like that recessive condition to lead to homozygous recessive, that is, they would not like to have any of their children affected with that condition, and they would opt, they have the option to opt to do genetic testing on the embryo before implantation, and then decide whether to implant that particular embryo or not. Of course, that I remember when the law was passed. I mean, before that law, there were a lot of discussions, and the compromise was that, okay, yes, pre-implantation genetic diagnosis is going to be allowed, but only for specific set of conditions, which basically include 9 conditions, which are all genetic conditions. For example, one of them being cystic fibrosis. And of course, there's counseling, which is mandatory both before doing the procedure and after. And yes, I mean, it's true that once that is allowed, there is a risk that in the future the list becomes more expanded. And, as we see in other countries, there is also the risk that eventually there could be these designer babies of like wanting to select the sex of the baby and wanting to select, other, let's say, superfluous characteristics like color of hair, etc. We are not there yet, and I hope we won't be there. But as we speak, of course, that technology is already present and it happens in a number of countries. Very often in the private sector where patients pay. And yes, so I'm just going to show you what pre-implantation genetic diagnosis entails. So here we've got the blastocyst now, right? So you've got the trophoblast and the abreuroblast would be over here. And what you'll see is that this pipette, let's say, will be taking a biopsy by taking some of the cells of the trophoblast. Okay, what you see here, you'll see the laser. So basically, this laser is there in order to put a hole within the zona pellucida, which is the outer covering of the embryo, of the blastocyst, I would say, the blastocyst. And then that creates a space for where the pipette is able to enter and take a few cells of the trophoblast. And the idea is that by taking those cells, you are, well, technically, you should not be impairing the growth of that embryo if that technique is done well. Of course, assuming that the technique is done well. At least the initial studies do not seem to show that it affects the growth of that particular embryo if that embryo is healthy. But of course, yes, I mean, there's still the chance that, I mean, you're sampling, you're doing this invasive technique, and if there is mosaicism, for example, you are not going to detect it anyway. So let's see. So you see the laser over here, and that laser has created a hole, and with the syringe, you see some of those trophoblast cells being extracted. I mean, the technique itself does look a little bit brutal, but in this way, a sample of the trophoblast is taken, genetic testing is done on that. Of course, I mean, the genetic testing which is done would be to, for example, let's say to see whether there's a cystic fibrosis gene or not. So it's a relatively fast procedure. In fact, you need to have that answer within 24 hours, because if you're doing this on the day 5 embryo, by day 5, day 6, the embryo needs to be transferred. I mean, it is done by of course people who are trained. It can't be done by any embryologist, because the idea is to biopsy without damaging the embryo. And again, using the laser, you're kind of cutting off that part of the trophoblast. So almost done. It does take quite some time. This is, by the way, a teaching video, so by someone who is trained, and still it takes some time. And that is the procedure. Okay. So let's move on now. Next slide. Okay. Risks of IVF to the mother. The most significant risk, apart from the pain, etc., is something called ovarian hyperstimulation syndrome, where the patient is like overreacts to the hormonal treatment. And instead of having, approximately 5 follicles per ovary, there are many, many more follicles which form, like let's say 20 per ovary. And of course, that is not a good thing at all. I mean, because all those follicles will be exuding a lot of edema and causing ascites, right? That ascites might not be limited only to the abdominal cavity, but might even lead to pulmonary edema, right? And the patient would very often need to be treated in intensive care. And the most important thing that someone who has hyperstimulation syndrome, the embryos cannot be transferred. So even if you have a system where you say, okay, I mean, we don't fertilize all the eggs, and we only fertilize a few in order to avoid having to undergo embryo freezing. But if the mother undergoes ovarian hyperstimulation, you can't put in the embryos because first of all, you lose the embryos, and secondly, her condition gets worse and can even lead to death of the mother. So in that case, the embryos would need to be frozen, and then you keep the mother in intensive care. You wait till this resolves by supportive care, basically, and only after the condition resolves can you continue with the rest of the IVF treatment. So that brings me back. So what do we do? When a couple, they come to see you, and maybe they've been trying for 6 months, they're otherwise healthy, they come to you very panicked because they still haven't got pregnant yet. There may be pressure from the family or from society. They need to have this baby. So I can tell you that what I do, right, and what many gynecologists who really care for the patient do is that you explain to them what is ovulation and when is the fertile time. I mean, remember, I do find medical students, nurses who, even though they are in the profession, they still don't understand their own fertility. You find many people thinking that they're fertile every day. I mean, females. I mean, male, you're fertile every day, but in females, you're fertile only around the time of ovulation. And especially if their period might be a bit irregular, they won't know when their ovulation is, or if their cycle is not 28 days, but might be 21 days or 35 days, they have no clue of when they're fertile. So by going through explaining, just spend, instead of having a 5-minute consultation, have at least a 15 to 20-minute consultation, and understand what the cycle is, and show them, how to recognize signs of ovulation. I can tell you that a big number of your 15% of patients who are not pregnant yet, and when they come with primary infertility, they will get pregnant. And then, yes, there will always be those people who need to be investigated, and let's say there is a very low sperm count or there is an ovulation who need help. But before resorting to IVF with all its problems, its physical problems, medical problems, emotional, ethical, you should spend some time to explain to the patient about the role of natural family planning, because it is the first step. Of course, it's free, it's easy to use, there are no side effects. It also helps to diagnose abnormalities. I mean, if you might even pick up that there are hormonal issues, and of course, then they do need to be investigated. But of course, the con is time. You actually need to sit down and explain to the couple. And as I said, I mean, you even have people who have been through STEM subjects and they have no clue about their fertility, let alone the rest of the people who might have never studied biology, right, or understood biology. So you need to sit down and explain. And of course, natural methods, like calendar method, glucose-based body temperature. These are the ovulation monitoring kits, which monitor the start of the fertile window. So they do mark when the LH happens, and you explain to them that the most fertile time is not when there is the first positive, but it's when, the couple of days following the LH surge, that is when it marks positive. And it's important to keep in mind that women ultimately are born with all the eggs they are going to have, and there is a reserve which has a lifetime, and eventually it will finish. And when it finishes, when that reserve of eggs finishes, then the woman enters menopause, and of course, her reproductive age is over, right? Her reproductive career is over. I mean, women, although we're born with about 2 million eggs, ultimately in a lifetime, a normal healthy woman would have about 500 ovulations. And pregnancy is more likely to happen around ovulation. So starting from about 3 days before ovulation until about a day after ovulation. The reason being because the sperm is able to stay healthy in the tube for up to 3 days before ovulation is happening. But once ovulation happens, the egg, although it's much larger than the sperm, the egg survives approximately 24 hours. Okay, so yes, I mean, age does play a role, both in females and in males. Okay, we do know that male partners over 45 years of age, there is an increased risk of miscarriage or congenital anomalies. And yes, sexually transmitted disease, weight problems, smoking, alcohol, even in men, they do lead to infertility. And as I was saying, so up to 84% of couples do get pregnant within 1 year of trying. And, as time goes by, of course, the chances do go down. And even if you were to attempt IVF, I mean, beyond, for example, the age of 45, I mean, the chances are still not very good. Okay, so that brings me to the end of the part on infertility. So are there any questions so far? Just check the chat. So I don't see any questions so far. So in that case, I can proceed to the second part, therefore. Okay, so let me. Sorry, is there a question? No, thought I heard someone ask a question. Okay, so let's just stop sharing for a second and share again. Give me a moment. Seem to have lost. Okay, no worries. Let's just go to this. Okay, and we'll go to the fetal placental unit. Just to confirm that you are seeing the fetal placental, the fetal maternal unit.
Yes, Prof, we can see it.
Thank you, Abigail. Okay, so fetal maternal unit or fetal placental unit. So basically, in the next half an hour or so, I'm going to be talking about the formation of the placenta from early pregnancy, from implantation onwards, and also introduce the topic of course, recurrent miscarriages, recurrent pregnancy loss, and also the fetal maternal unit. This will then also serve as the basis for tomorrow's lecture, when we'll be talking on diseases of the placenta, such as preeclampsia and other pregnancy conditions. Okay, so when we're talking about the fetal maternal unit, I'm of course referring to the placenta which is connected to the baby by means of the umbilical cord. Okay, so once the embryo has implanted, the embryo will of course form from the inner cell mass, but the trophoblast, outer part, will divide into two sections. There is what we call the cytotrophoblast and the syncytiotrophoblast. And by the end of the second week, right, this syncytiotrophoblast, which is the outer part, right, of the trophoblast, would have started to, let's say, would have implanted, would have finished implantation, and would have started to lead to the formation of villi, which are there in order to serve as the surface area for transportation of nutrients from the mother to the fetus, and of course for the fetus to excrete CO2 and other waste products of metabolism to the maternal circulation in order to be removed. So if I were to take this implanted embryo and somehow dissect it out, right, from the decidua, this is what I would see. So initially, the embryo, if I were to divide this, the embryo would be on the inside, and on the outside, all 360, all out the outside, the sphere, which is keeping the embryo on the inside, would actually be the trophoblast. And we call that the chorion frondosum. And if you zoom in, each of this is a little villus. Now, the chorion is ultimately what is going to lead to the formation of the placenta. But of course, we all know that the placenta is not found 360 degrees, all around the embryo and the fetus. It's impossible, because otherwise it would mean that for the fetus to be born, it would have to rupture its own placenta. So that's not, of course, what happens. So what happens is that over the first trimester, so over the first 12 weeks, the part of the chorion, which is going to lead to the formation of the actual placenta, will persist in terms of chorion frondosum and will actually continue growing in order to form the placenta, while the rest of the chorion frondosum, which is away from the future placenta, will become what we call the chorion leve. So the villi will become more sparse, and what remains, the thin membrane which remains, will be the amniotic cavity, right? And by that it means that when the baby is about to be born, it's the amniotic cavity which ruptures, right? The fluid comes out, and the placenta stays stuck to the uterus for as long as labor ensues. And then when the baby is about to be born and the head is, of course, crowning, and then when the baby is born and you cut the cord, then the placenta, of course, is delivered as well. It's part of the third stage of labor. Okay, so this is the transformation of the chorion frondosum to the chorion leve, forming the amniotic membrane, and the chorion frondosum will then become the actual placenta. So how does this take part? Now, this is very important to understand, because myself, and I was a medical student, we were always taught that from the beginning, the embryo needs oxygen. And the embryo does need oxygen, but actually, initially, the oxygen actually helps to shape this transformation of the chorion frondosum into the chorion leve and the formation of the placenta and the membranes. So how does that happen? So basically, the first trimester placenta, okay, initially, its role is actually to minimize the amount of oxygen reaching the developmental tissues. And then, as oxygen continues trying to reach the developing embryo, the physiological oxidative stress is actually for the transformation of the chorion frondosome into chorion lever, and villi regress, right? And you get this physiological remodeling where part of the placenta, part of the chorion frondosome will lead to the formation of the actual placenta, and the rest will become the membranes. And that is the role of oxygen metabolism and the oxygen-free radicals, which initially they help to remodel the placenta. Now that happens in the very beginning of pregnancy. So starting from implantation till the first few weeks of the first trimester. And if that happens properly, then you've got a successful pregnancy because the placenta forms normally, the membranes form normally. If it happens in an imbalanced way, it's going to lead to some kind of problem, as we're going to see. And this work happened in the early 2000s. Okay, so that's when this dogma, let's say, where we used to think that oxygen is useful from the beginning and is necessary. I mean, it is necessary, but actually, initially, it has like this controlled damage effect on the placenta in order to shape the placenta. And if it gets it right, then the placenta is going to form normally and is going to lead to a successful pregnancy. If it doesn't happen, the type of detriment that it can cause can range from an early miscarriage to preeclampsia or premature delivery. So let's see what causes that. Now, the mechanism that this happens, so oxygen, the way that oxygen is working on the placenta by means of oxygen radicals, we know that there are also these special substances like hormones called cytokines, which play a big role together with our immune system in order to help with the placentation and with the acceptance of this foreign embryo, being accepted by the maternal unit, by the maternal side. And just to put it simply, because we could go on and on and on to talk about this, but T1 helper cells secrete cytokines, which include TNF and interferon and interleukins, which is a type of immune response, cell-mediated immune response. There are these two T2 helper cytokines, which are more humoral, that is more in terms of interleukins, and these depending on the balance that there is between these Th2, T helper 2, and T helper 1 immune response, that is the cell-mediated, the humoral versus the cell-mediated, if there is, the right amount of anti-inflammatory cytokines, that is the T helper 2, that's good. There's a strong association between the T helper 2 immunity and successful pregnancy. But if there is a shift more towards the pro-inflammatory, so more cell-mediated TNF, cytokines, interferon, etc., there's a strong association between this T helper 1 type immunity and pregnancy loss, or if not pregnancy loss, problems with placentation, such as preeclampsia and premature delivery. So what is this link? And here I'm happy to say that this actually was part also of the PhD work that I had carried out in my time in London. So the link between early pregnancy, oxidative stress, and cytokines. So pregnancy, normal human healthy pregnancy, there is a degree of oxidative stress which happens, which I mentioned before, where you've got the oxygen, which is creating this oxidative stress. It's important in physiologically modeling the placenta in such a way that it transforms the placenta and the membranes. And we also know that pregnancy is a state of systemic inflammation. I mean, there is, of course, the embryo who is foreign, and it needs to be accepted by the uterus, by the maternal side. So there is some degree of blinding from the maternal side in order not to reject the embryo. So there is this systemic inflammation, which tends to be what we call a T helper 2 phenomenon, so involving the anti-inflammatory cytokines, so the mother doesn't reject the implanting embryo. And there is this balance, which when it happens, when it works, that's going to lead to a normal healthy pregnancy with a normal healthy live birth. However, if there is too much oxidative stress, with a lot of oxygen-free radicals, leading to a lot of pro-inflammatory cytokines like TNF-alpha, if that happens early, it's going to lead to an increase in the apoptosis, and that increase in apoptosis, if it happens early, that's going to lead to miscarriage. If that happens a bit later on in the trimester, that's going to lead to problems like preeclampsia, premature rupture of membranes, and intrauterine growth restriction, because the placenta hasn't formed properly. In the case of systemic inflammation, it's the same. If there is an imbalance between the Th2 and Th1, and there is excess inflammation with the Th2 helper 2 becoming more cell-mediated and more TNF, again, if that happens early, it's going to lead to miscarriage. If that happens later, it's going to lead to problems of insufficient placenta, insufficient placentation, leading to preeclampsia, premature rupture of membranes, and intrauterine growth restriction. And this has been shown in the work, as I said, which happened in the early 2000s by Professor Jonio, who was one of my PhD supervisors, who showed how this happens in miscarriage. Now, that brings us to the last part of our lecture, which is miscarriage and then recurrent miscarriage. So the risk of miscarriage is, it is the commonest reason why patients come to visit gynecology emergency department, and it happens in up to 20% of pregnancies, like 1 in 5 pregnancies, especially if you include the early losses. So patient does a pregnancy test at home and it marks as positive, and then a few days later, a few weeks later, it starts bleeding. If you were to wait till the pregnancy is visible on ultrasound, of course, the numbers are a little bit less, like 15%, that's because a number of them would be lost before. And if you were to count all the biochemical pregnancies, of course, the number is even higher. Now, the risk of having a further miscarriage after 2 miscarriages is up to 20%, but after having 3 miscarriages, it rises to 40%. So in that case, so while a spontaneous miscarriage, the very first miscarriage, normally we assure the patient that the chances are, because there was a congenital anomaly affecting the pregnancy, and therefore, like the nature's way of quality control, stop the pregnancy. But when it becomes 2 recurrent miscarriages with no previous healthy pregnancy, or even more so if there were 3 miscarriages, then it's also very possible that the problem isn't just a congenital problem affecting that particular embryo, but more likely that there is an underlying issue either in the mother or in the genetics of the embryo, like there is a recurrent aneuploidy which is happening, probably because it is heritable and it has been inherited. So when we define recurrent miscarriage, for a long time, there has been the definition of waiting for 3 consecutive miscarriages before labeling a patient as having recurrent miscarriage. Basically, it's because it reflects statistics and also reflects cost effectiveness, because if you're having a national health system which is public, then of course to be more cost effective, they would wait for 3 consecutive miscarriages before starting treatment. But in reality, live birth rates do fall do fall well after 3 losses, but there is also the case that there is also an increasingly adverse prognosis even after having 2 recurrent miscarriages. So if you look at the pregnancy, what we call the pregnancy iceberg, actually this is a very old diagram from the 1960s, but I think it still holds. Of course, out of every pregnancy, clinical pregnancy, the risk of miscarriage is 1 in 5, even 1 in 4 in some cases. But if you were to look at all conceptions, every conception, the chance of having a live birth is actually 30%. So what are the risk factors for miscarriages and even more so for recurrent miscarriages? So the commonest reason is an aneuploidy, so a problem, the genetics of the embryo. However, if it is a spontaneous mutation which affects one embryo, it's like having an accident. So the risk of having an accident, so if I go out and I'm run over by a car, okay, that was an accident, the risk of that happening again is very unlikely, unless there's something wrong with me or with the system. So if a mother has a miscarriage and that one miscarriage is an aneuploidy, that is, there is a problem with the genetics of that embryo, actually her chances of having another pregnancy which is healthy are quite high. It would be even more difficult, let's say even more problematic if her miscarriage had the normal genetics, because what that would mean if she miscarried a normal genetically normal embryo, then it's more likely that the problem is with her. That is, she has some inflammatory condition which is rejecting the healthy pregnancy. All right, and of course, if the miscarriage happens later, so it's not an early miscarriage, but it is a second trimester loss, the risk factor for a poor prognosis is higher, mainly because, again, it's more likely to be a problem with placentation. So if we were to look at reasons for recurrent miscarriages, so yes, you do have genetic defects, which could be heritable, but the commonest are, of course, idiopathic. You might never find the reason, but the common treatable causes are autoimmune conditions, thrombophilias, right, problems with clotting, which could be acquired or inherited. Of course, there could be endocrine disorders like thyroid, diabetes, or the polyendocrine metabolic ovarian syndrome, or anatomical abnormalities within the uterus, like normally shaped uterus. So, of course, yes, in the ideal conditions, you do carry out genetics of recurrent pregnancy loss, and the genetics not only of the parents, but even of the embryo. Of course, it's not always possible. It is expensive, like doing genetic testing on the products of conception. Also, by the time that the mother passes the products and by the time they reach the lab, they might have already deteriorated in such a way that you can't do genetic testing. But in reality, that is the only test which gives you a definite cause behind the particular miscarriage. Now, in our case, that normally happens after the third miscarriage. Because it is expensive to carry out before that. And I'm aware that in many countries, it's not done at all. So how do we manage? So I'm going to share here our experience of the recurrent miscarriage clinic, which we have at our national hospital. And it had been set up, I think now for about, I would say about 20 years now. And it is good because you have a team of dedicated staff. So the patient, the couple, they see the same doctors, they're followed up, and the staff actually is made up of one consultant and 2 specialists and a number of trainees. There's a midwife and a nurse practitioner, and there's also the service of a psychologist, because we do know that especially in cases of idiopathic unexplained recurrent miscarriage, tender loving care is very important. So of course, also important even in the other cases where you have a cause, but especially in the unexplained. These are the tests that we carry out. There is an immunological profile which is carried out, ripen, antinuclear factor, anti-double-stranded DNA. This is basically looking for conditions like lupus, systemic lupus erythematosus, and other autoimmune conditions. There is also a thrombophilia screen, which is carried out mainly for protein S and protein C, and antithrombin, and factor V Leiden, and homocysteine, and also factor 2. There is also an endocrine profile. Of course, we do the hormone tests, and we also do the thyroid tests, and we check for diabetes via the oral glucose tolerance test. The parents undergo karyotyping, and when possible, especially if it is after their 3rd miscarriage, when the products are available, chromosomal, the genetics of the products of conception are carried out. And in that case, genetic counseling is carried out, and if turns out that there is a mutation which the parents are passing on continuously to the fetus, then it's also possible to consider pre-implantation genetic diagnosis. If the mutation is found. We out a pelvic ultrasound where you can see, for example, if there is a pivot pingogram to confirm tubal patency, and again that the cavity, especially the cavity, is normal. And then patients are managed also within that clinic. At least they're managed until they're pregnant again and well into their 1st trimester. And the role of supportive care, which is very important. And, that starts, with every visit. When they do get pregnant again, there's an early ultrasound in order to reassure, to call a reassurance scan. And of course, if they have a miscarriage, they're admitted to hospital. And then, depending on the causes, so if it is polycystic syndrome, so the polyendocrine metabolic ovarian syndrome, they get metformin, or if they are pregnant, they get anti-estrogens like clomiphene. If there are endocrine issues like thyroid, they get treated. If there's hyperprolactinemia, they get treated. If there are anatomical abnormalities like fibroids, the fibroids get treated. Or if there is cervical incompetence, like they get a cerclage after confirmation of the next pregnancy, and they're going into their. If there are autoimmune conditions, they get a prednisone, and they get anticoagulants if there are thrombophilias, and of course, and that actually where we've been talking about infertility, then we went on to talk about the fetal maternal unit, and then we also talked about recurrent miscarriages, and I ended up with how they're treated in my hospital. So this, by the way, is a prehistoric figurine, which was found in one of the prehistoric temples in my country, in Malta, 1,000 years before Christ. It's actually a very small statue, about 15 centimeters, and we say it's the sleeping lady, and it's thought to be like the goddess people in Malta used to pray to, in order to get rain, so that the land is more fertile, and of course also for their own fertility issues. So I'm going to stop sharing and I'm open for any questions or any clarifications that you'd like to have.
Thank you so much, Prof, for the amazing presentation. We really appreciate it. Colleagues, please, if you have any questions, you can kindly unmute yourself and ask so that Prof will be able to clarify whatever you want to know. Thank you so much.
Thank you. It seems that yes.
Are there any questions, please?
Yes, I think someone asked them can get the slide and recordings. Definitely the recordings, and I can send you the slides, even of the last session.
Yes, please. Yes, please. The recordings are available, Dr. Ajiman.
Okay. And we're meeting again tomorrow. So
yes, please. Yes, please. If there are no questions, we would like to thank Prof. The amazing presentation given to us. It was very insightful. A lot has been learned today. And I would want to thank each and everyone who was able to join their presentation. So we really appreciate your time and your efforts. So without wasting much time, we would thank Prof and then we will end this session and prepare for the next section. Richie, will you be available to put it on the screen for us so we will be able to know the next session, please?
So I'm not sure if I have. I don't think I have a screenshot of it, but I'm going to. Just going to.
It's gonna be tomorrow. I had just
tomorrow?
wanted us. Yes, please, 22nd. Yes, please. And we are studying on red cell aluminization.
Yes.
Diabetes and metabolic disorders in pregnancy and preeclampsia. That is from 2:30 p.m.
Yes.
to 4:30 p.m.
I was trying to find the slide for that because I know that the timetable had been updated even with the times.
Yes, please. Yes,
but
please.
That's exactly what we're going to be covering tomorrow.
Yes. So kindly join in early so we'll be able to finish everything you're supposed to study. Thank you all so much and have a nice day. Thank you, Prof.
Thank you so much. I look forward to seeing you tomorrow. Thank you.
Sure. Thank you. Bye.
Thank you, Abigail. Bye-bye.